Morning, everyone. We are really excited to have Dr. Ziv Harel from St. Mike's present to us on the topic that is near and dear to many of us every time we see a patient like this in the dialysis unit. So Dr. Harel is a nephrologist. He's an associate professor at St. Mike's Hospital and UHN in Toronto. He's done his training mostly in Toronto with a med school in London at the Western University. Apart from that, he's got a master's in Clin Epi from UFT. He's also a scholar was a scholar at the Women's College Hospital, if I'm not wrong. He has done his main interest is in, of course, doing studies in dialysis patients, and he's got funding from CIHR, Kidney Foundation, and other agencies. And he led the SAFE-D trial that we were a part of. So this is extremely timely. Go ahead, Ziv.
Okay, thanks so much, and good morning, everybody. It's really great to join you and talk about this issue, which has been vexing many of us for a number of years. So today I'm going to speak about the role of oral anticoagulation in dialysis recipients with atrial fibrillation, and I've entitled the presentation as the beat goes on. So just quickly, I have a few disclosures. I've received grant funding from the Canadian Institutes of Health Research, the Kidney Foundation of Canada, and from St. Michael's Hospital through the Mary Papin-20 Fund. So I think this slide really encapsulates where we've been and certainly where we are right now in terms of managing atrial fibrillation. So if you're really confused about it and vexed about this topic, you're really not alone. As this slide demonstrates. So this was a survey that was done back in 2015 of cardiologists who worked at 41 electrophysiology centers of excellence in Europe. And basically what they did is they asked in the survey, they gave them a bunch of scenarios and asked them how they would manage the anticoagulation for patients on dialysis who have atrial fibrillation. And as you can see from the bar graph, the responses were quite varied, and that really indicates that nobody really clearly understood at that point in time what the correct answer is, and that sort of rings true to today too. But you know, us and other people are working on really trying to answer that question. So my objectives today are threefold. Firstly, I want to highlight why managing atrial fibrillation is important and to discuss its epidemiology specifically related to dialysis recipients. I want to also demonstrate to you that equipoise exists regarding the administration of oral anticoagulation in dialysis recipients with atrial fibrillation. And finally, I want to present the results of the SAFE-D trial, which was a pilot study that Ron and I were co-PIs on, and your center certainly contributed to that, compare different anticoagulation strategies in dialysis recipients who have atrial fibrillation. So the first question is, why should we care about managing atrial fibrillation? And we all know that atrial fibrillation is an important disease to manage, not only because it's associated with an increase of stroke, an increase of heart failure and death, but it's also a multi-system disease. It affects individuals' cognition and is associated with vascular dementia. It affects people's mental health, and with that also impairs their quality of life, not only through the mental health components, but and the strokes and the other conditions with it, but also the fact that these individuals are at increased risk of hospitalization. And we know that individuals who have chronic kidney disease, especially those with advanced chronic kidney disease and those being on dialysis, have a substantially higher risk of these outcomes. As you know, there are multiple risk factors in dialysis recipients for atrial fibrillation. We have the classic, CHADS-VASc incorporated risk factors, which are shown on the left here. But in our dialysis recipients, there are also additional risk factors that sort of propagate the substrate of atrial fibrillation. As we dialyze patients, there are large electrolyte fluxes across the membrane, which hyperexcites the myocardium. There are hemodynamic changes that occur during dialysis. Our patients are also in a state of chronic volume overload, and the dialysis procedure in itself may lead to some oxidative stress. And all those specific factors related to dialysis may propagate atrial fibrillation further by contributing to its substrate. So we know that AFib is very highly prevalent in dialysis recipients, and Deb Zimmerman nicely demonstrated this back in 2012 when she actually performed the first systematic review that summarized the totality of the evidence of atrial fibrillation in the dialysis population. And at that time, using administrative data and chart reviews, the prevalence was noted to be about 11.6%. And if you compare that to the general population, atrial fibrillation is actually almost 5 times more prevalent in dialysis recipients than in the general population. But because of all the inherent factors that may happen during dialysis, it's thought that maybe patients who are on dialysis have a higher burden or a higher prevalence of atrial fibrillation that we're really just not detecting with these chart reviews and through administrative data. And Dave Sheridan who's now at NYU, actually did a really nice study looking at this when he was back in Boston. He implanted a loop recorder, which looks like this USB key, in about 40 patients, and followed them for 6 months, interrogating this recorder every few weeks to see what arrhythmias occur. And what he found was quite interesting. He actually detected atrial fibrillation in 40% of patients. And he found that atrial fibrillation mostly associates with the hemodialysis procedure, as demonstrated by these large bars. And the highest prevalence of atrial fibrillation actually occurred after the long intradialytic interval, which makes intuitive sense because that's a time when patients are most volume overloaded, they're most hyperkalemic, and there are these large fluxes across the membrane. We know that atrial fibrillation in general is increasing in prevalence in the general population, pretty much across both sexes and in pretty much all age groups, and particularly in the elderly. And this really rings true in the CKD population as well. And one of my graduate students, Sarah Wing, is looking at this using ICS data, and hopefully is going to present her findings in a few months. So the next question herein is, what factors do we need to consider when deciding on how to manage atrial fibrillation patients who are on dialysis? And we all know that atrial fibrillation is associated with an increased risk of stroke, and that risk is graded such that the worse your kidney function is, the higher your risk of stroke is, and that's been demonstrated in multiple studies. But we also know that dialysis patients, aside from having an increased propensity to clot, also bleed much more frequently. And Manish showed this a number of years ago with a pivotal study looking at major bleeding in individuals who are on dialysis. And what he demonstrated was that 1 in 7 dialysis recipients will have a major bleeding event within 3 years of starting dialysis. And this is particularly most marked in elderly individuals, and those are the ones that also have the highest prevalence of atrial fibrillation, where their risk of major bleeding is almost 14%. And if you compare that to the general population, which is almost 2%, that's strikingly high. Now, again, major bleeding is a standard definition by the ISTH, and it consists of bleeding that's either fatal, bleeding that's associated with a drop in hemoglobin of more than 20 grams per liter, bleeding that's associated with 2 or more units of packed red blood cell transfusion, or that which occurs in a critical site. So certainly not a trivial event. And so individuals may say, well, stroke is really the main thing that we should care about when we consider managing atrial fibrillation with oral anticoagulation. And people bleed, but that trade-off is worthwhile. Well, that has some merit to it, but as we could see from this study, bleeding in dialysis patients isn't benign, and it's certainly not trivial. This was a study that looked at individuals who were on dialysis who either had atrial fibrillation, and they looked at their outcomes after either a stroke event, a bleeding event, or an MI, and particularly focused on mortality. And as you could see, their risk is markedly elevated, especially in the elderly individuals, such that compared to the general population, individuals who bleed have an almost 10 times increased risk of mortality. And although stroke has a much higher mortality rate than bleeding, bleeding in itself is not trivial and is associated with quite a lot of mortality. The other thing that we have to consider is our dialysis patients are sick. They have multiple other comorbidities, and they have a very high rate of mortality. And as we all know, there's about a 10% mortality rate over each year in our dialysis recipients. And that's pretty much comparable to severe heart failure. And when you describe this to cardiologists, sometimes they're taken aback because they don't appreciate sometimes that being on dialysis is associated with such a high degree of mortality. And certainly we have to factor that into our assessment of patients as to how we manage them. So we know that mortality is certainly a competing risk in terms of stroke and bleeding events. And this was nicely demonstrated almost 8 years ago now in a study out of Taiwan. So in East Asia, they don't anticoagulate pretty much all of their atrial fibrillation patients who are on dialysis. And so it brings up quite an appropriate natural experiment where you can compare individuals who have AFib who are on dialysis versus those who don't have AFib or on dialysis. And this is what this group did. And I just want you to look at the box here. So when we look at various outcomes such as death, ischemic stroke, and hemorrhagic stroke, when they just do adjusted modeling for a number of covariates, you could see that individuals who have atrial fibrillation and are on dialysis have a significantly higher risk of all these outcomes compared to those who don't have atrial fibrillation. But when you start accounting for the competing risk of death, that that attenuates the high risk of those outcomes, such that the risk of stroke and both ischemic and hemorrhagic becomes non-significant, and only really the risk of in-hospital cardiovascular death is significant. So, when we look at how we should manage atrial fibrillation patients with oral anticoagulation, it's not just a binary decision, yes or no. We have to look at bleeding events. We have to look at the risk of thromboembolism, but we also have to consider the risk of mortality in these individuals as well to determine whether there's a net clinical benefit to really treating them. And so that's where therein the complexity lies. So we know in the general population that there's very robust evidence for the role of anticoagulation in treating atrial fibrillation, because the reduction in stroke is much greater than the risk of bleeding. And this is true for both warfarin and for the DOACs. And these are just some of the seminal studies on the left side of the slide. In warfarin, where there's about in total a 60% relative risk reduction. And on the right side, this is for the DOACs, where they're pretty much non-inferior. And again, this is in the general population. But what's interesting is that in individuals with advanced CKD, in particular those with end-stage kidney disease, they've all been excluded from those trials. And so therefore, we're really flying blind in managing these individuals and knowing what to do, because we don't have gold standard evidence for how to manage them. And this uncertainty really filters or trickles down into the current guidelines that are out there in terms of how to manage individuals who have atrial fibrillation that are receiving dialysis. The American Heart Association says that for individuals with atrial fibrillation who have an elevated risk of stroke and are on dialysis, it may be reasonable to prescribe warfarin or apixaban. The Canadian Cardiovascular Society says they don't routinely recommend giving individuals OAC for stroke prevention. KDIGO says there's insufficient high-quality evidence for managing these patients. And similarly with the European Society of Cardiology, they echo the same type of conclusions there. And this is really because the evidence is quite poor. It's grade 2B and not really based on much randomized control trial evidence. So the next natural question is, what's the evidence for these guidelines? And it's primarily observational data, and to be quite frank, it's based on poor observational data. This is a network meta-analysis that was recently published that looked at individuals who have atrial fibrillation and are receiving dialysis. And they wanted to look at both stroke and thromboembolism events, systemic embolism events, as well as bleeding outcomes. In total, this study is the largest to date. It incorporated 42 studies of almost 180,000 patients. But there have only been 3 randomized control trials that were included in this analysis. So if we just focus on the left side of the screen here, just use the laser pointer. What's cool about network meta-analyses is that they allow you to compare different treatments against one another. So here we're looking at no anticoagulation. We're looking at anticoagulation of the vitamin K antagonist and DOACs, and anticoagulation with DOACs. And so if you look at DOACs versus none, there are 2 studies that they included in this network meta-analysis. If you look at VKA versus no oral anticoagulation, there are 27 studies that are included. And VKAs versus DOACs, there's 7 included studies for that comparison. And 3 of those are randomized control trials, which I'll tell you about later on. But if we look at the force plot here, what we could see is that when we compare VKAs or DOACs to no oral anticoagulation as the reference, there's really no significant signal there. VKs, if you look at everything here, VKs may slightly increase the risk of thromboembolism, but again, the confidence intervals cross 1. And similarly for DOACs, there may be a slight decrease in the risk of thromboembolism, but again, that's non-significant. And it's a very large confidence interval, meaning there's a lot of uncertainty there. Similarly, when you compare DOACs to vitamin K antagonists, you sort of get the same signal, a non-significant one with a possible trend towards a decreased risk. If we look at bleeding events, it's a similar picture. When you compare DOACs to no oral anticoagulants, there is a slight signal towards an increased risk of bleeding, but again, that's not significant. Vitamin K antagonists are significantly have an increased risk of bleeding compared to no oral anticoagulants. And when you compare DOACs to VKA, we could see that there's a decreased risk of bleeding. But there's a big problem with these studies in that the majority of these studies are very poor quality and they're very highly heterogeneous. Although they're observational in general and give us a real world sort of look at what's going on, they're very highly confounded and they're especially prone to confounding by indication. The other problem with these studies is they really use non-standardized definitions for bleeding and thromboembolism. So we don't really know if something is counted as a major bleed in one study and a minor bleed in the other. And they really don't help us address the underlying question of, should we anticoagulate these patients? And I think, this is a study, a meta-analysis that was done in 2024, even after these guidelines. But, the same premise holds that the quality of guideline, the quality of the evidence upon which these guidelines are based is quite poor. So the next question is really, okay, you're going to anticoagulate. What is the optimal oral anticoagulant? And we know that vitamin K antagonists have traditionally been our go-to choice of anticoagulating individuals with atrial fibrillation, but they're quite fraught with a lot of issues, which lead people to possibly preclude using them. We all know that they're associated with an increased risk of calciphylaxis, accelerated vascular calcification. They increase your risk of bleeding, as the meta-analysis demonstrated. And despite us being having our patients in a dialysis unit where they have access to essentially point of care INR measurements and healthcare practitioners pretty much always there, the time in the therapeutic range is poorly maintained. And as we know, the time in the therapeutic range is really the most important marker telling us about the quality of anticoagulation, such that a time in the therapeutic range greater than 65% is associated with a decreased risk of stroke, and having a time in the therapeutic range less than 65% increases the risk of stroke and bleeding events. And this was actually a large study here in the bar graph, in the line graph out of the VA, that looked at individuals across different strata of kidney function. And as you can see, in individuals who are on dialysis, and I'll just highlight this purple line here, that the time in the therapeutic range is about 43%. So that's really quite poor. And that may partially explain why there's an increased risk of bleeding in these patients and strokes, but that's not fully explaining the whole story. Well, what about DOACs? Again, with DOACs, there's really unclear efficacy in terms of their role in preventing stroke and systemic embolism. And again, as I showed you in the previous slides, the evidence upon which that's based is quite weak. And DOACs are also variably eliminated by the kidneys, and that leads to further uncertainty with regards to bleeding outcomes. So, for example, dabigatran is much more renally eliminated than apixaban, and if individuals choose to use dabi versus apixaban, they may have a much higher risk of bleeding in those patients. So how are we really managing, based on what I've shown you, how are patients being managed in the dialysis unit for those who have atrial fibrillation? And again, this slide really highlights where we are now. It's sort of an old one that's almost 15 years now, but it shows you that there's quite a lot of variability that's happening in the world because we really don't know what the right answer is. So if we look at this bar graph here, the different colors of each bar demonstrate a different type of management strategy. So as you can see in Canada and Australia, New Zealand, and the United States, it's about a third, a third, a third. A third of patients do not receive any anticoagulation. A third receive aspirin therapy, which actually it doesn't really do much in terms of anticoagulation. And about a third receive warfarin. If we look at Japan, as I mentioned previously, the majority of individuals receive no therapy, and Europe tends to almost do the same thing that East Asia does, where the majority of patients do not get therapy. We also know now that that warfarin is sort of becoming a product of a bygone era, or as Manish nicely titled in one of the editorials that we wrote, it's been relegated to the pharmaceutical dustbin. And as we could see from this study, that apixaban use is increasing dramatically in dialysis recipients, and that's coming at the cost of warfarin and other vitamin K antagonists. And again, this only goes until 2018, but the same trend, if we look to more recent times, this trend is continuing, and more individuals are getting apixaban as we're becoming more used to it in managing dialysis patients with DOACs. So the question is, where do we go from here? We have atrial fibrillation, certainly a problem in individuals who are on dialysis. It's associated with really bad outcomes. We don't really have great evidence to how to manage these patients. So what can we do? How do we improve care for our patients? And so there's a clear consensus that we need a definitive randomized control trial. And it really needs to answer two questions. One, should we anticoagulate our patients? And two, if we should, what's the optimal agent? And so there have been a number of randomized control trials that have undertaken such an endeavor. And for the most part, a lot of them haven't been successful. There was, you're all aware of the renal AF study, which was based out of the United States, comparing apixaban to warfarin. And they wanted to recruit almost 900 patients, but they stopped at 155 because of poor enrollment. There was also the Exadia trial out of Germany that looked at low-dose compared to low-dose warfarin, low-dose apixaban versus warfarin. And again, they wanted to compare, they wanted to enroll 200 patients, but they stopped after enrolling 97 participants, again, because of recruitment issues. And the criticism of those studies was how can we say that we should anticoagulate patients when we don't even know the first step? You know, how can we give an anticoagulant when we don't even know if we should anticoagulate individuals? So there was a study in France that started in 2016 that wanted to compare warfarin versus no anticoagulation. And they've recently stopped their study after recruiting only 80 patients out of a target of 855. There's a downward study in Denmark that's it is actually recruiting now, but its recruitment target is 719 patients, and they're comparing warfarin to no oral anticoagulation. And I'm not really sure if they're going to be able to recruit either. So this is certainly a definite problem. We're seeing a trend here whereby, you know, we're investing a lot of time, effort, and money into large randomized control trials that aren't being completed. So Ron and I thought about this for a long time before deciding to embark on a study. And we said, before doing a large study and wasting everybody's time and wasting money and energy, what are some key questions that we should think about? And the most important thing that we thought of is it feasible to do a large trial? Meaning, will clinicians agree to participate? Will eligible patients agree to participate in the trial? Can we ensure that patients will adhere to their assigned treatment regimen? And can we also ensure that there's going to be adequate follow-up in the trial? And that really brought up the issue of doing a pilot trial and the imperative of doing a pilot trial in this area before taking on a much larger trial. So that's what we did. We devised this study with a really great steering committee that was entitled the Safety Study, which stands for the Strategies for the Management of Atrial Fibrillation in Patients Receiving Dialysis. And it was a pilot study, which I'll show you. So the overview of the study was we enrolled individuals who have non-valvular atrial fibrillation, and they satisfy the CHAD 65 criteria. The CHAD 65 criteria is basically a Canadian type of version of the CHADS 2. Basically, if you have any of the CHADS risk factors or you're over 65, you get into, it's decided that you should get anticoagulation. We also included individuals who are receiving both hemodialysis and peritoneal dialysis because we wanted to have our study be generalizable. There were a number of exclusion criteria, which I'll go into more detail in a different slide. And we wanted to look at a sample of 150 patients. And again, we didn't do any statistical sampling calculations because this was a pilot study focused on feasibility. And we looked to other studies that were done, such as phosphate, that had pilot studies to help guide us as to an appropriate sample size. So we decided our sample size should be 150 and 50 should go into each group by block randomization. So people were randomized 1:1:1 to either receive apixaban 5 milligrams twice a day, and there were provisions for using a lower dose, which I'll talk to you about in a little bit, dose adjusted warfarin, or no oral anticoagulation group as the third arm of the trial. And our primary outcome was feasibility based. We wanted to see if we can recruit these 150 patients within a 2-year time frame, and if the patients will adhere to their assigned treatment regimen within a 6-month treatment duration. So this was our inclusion criteria. We used quite a broad criteria for including individuals with atrial fibrillation and atrial flutter, which is essentially managed the same. And this criteria was used by the renal AF study, so there is quite a good face validity to it. And again, as I mentioned, individuals had to satisfy the CHAD 65 criteria, meaning they're over 65 or they were less than 65 and had any one of the following conditions. As I mentioned previous, there are a number of important exclusion criteria for the study that I'll let you look at, but I just want to highlight numbers 9 and 10, which really brings up the issue of, you know, the physician being involved here. Firstly, if they felt that there's no equipoise, then certainly they wouldn't recruit they wouldn't allow their patients to be recruited into the trial. So as I said, our primary objective was feasibility based. We wanted to see if we can recruit the target population within 2 years of starting the trial, and that at least 80% of randomized participants would remain in the trial and on their allocated study treatment at the end of the 26-week study period. We had a number of secondary objectives really to ensure that that we were looking at important outcomes that would help with sampling calculations for a future trial, and that we would understand what some additional barriers would be in terms of recruitment or other issues with the trial. So we wanted to see how many patients randomized to warfarin achieved the time in the therapeutic range more than 65. We wanted obviously to make sure that we were recruiting patients who had atrial fibrillation. So we had cardiac diagnostics and EKGs adjudicated independently by cardiologists. And there were a number of important clinical outcomes that would help guide sample size calculations for a future trial. So we looked at bleeding events, we looked at stroke and systemic embolism, mortality, a number of cardiovascular and vascular events, and a number of special events related to either the dialysis procedure or dialysis access. So our interventions were, as I said, threefold. One arm was dose-adjusted warfarin targeting an INR of 2 to 3, and we wanted to be very pragmatic. We said to our sites, you know, you adjust the warfarin doses as per your local policies, but we did provide sort of a guideline as to how to make adjustments. I'm not sure what the uptake for that was, but I'll show you what the TTR was in a couple of slides. For the apixaban group, we wanted to use the standard dose of apixaban, 5 milligrams twice a day, because renal AF was using that, and this is again before they published their pharmacokinetic data. But we also allowed our investigators to use 2.5 if certain criteria were met. So there was the weight or age criteria, which would be standardized adjustment criteria, or if the local investigator felt that the bleeding risk of the patient was too high on 5 milligrams of apixaban, and they felt a lower dose was more appropriate. And the final arm was no OAC. We had 28 centers in total participating in our trial, 24 in Canada and 4 in Australia. And these centers were both academic centers and community hospitals, which actually improved the generalizability of this trial. So we started recruiting in December 2019, and we actually finished recruiting in 2022. So our total recruitment time was completed within 30 months, which was a little bit longer than the 2-year time frame that was our feasibility outcome number one. But we have to take this with a little bit of a grain of salt, because there was the COVID pandemic occurring during 2020, and pretty much like most sites stopped recruiting between March and October of 2020. So when you account for that, we actually did meet our first feasibility outcome. But I want to go through the consort diagram with you. So in total, 892 dialysis recipients were screened, and of those, 741 were excluded, leaving 151 individuals randomized. Of the 741 that were excluded, 411 had very hard exclusion criteria, which are listed there for you to look at. But what's really important is 330 patients were eligible. They met eligibility for the study, but were excluded. And the most common reason for exclusion in almost 2/3 of cases were individuals declined to participate, either because they weren't interested in participating in research, or they were just happy being on their current oral anticoagulant, or they just didn't want to be on an oral anticoagulant. There were 102 eligible dialysis recipients for which the clinicians felt there wasn't any clinical equipoise, and we can sort of argue about that a little bit, but again, it's certainly the clinician's decision. But it's quite striking that almost half of all excluded patients were actually eligible for the study, but were excluded. And so, as Ron kept telling me, we could have done this trial like 3 times over within the time period if we could only somehow enroll such patients. So in the end, 51 patients were randomized to apixaban, 52 were randomized to warfarin. 1 individual withdrew from the study later on after they had a fall and didn't want to be on an oral anticoagulant, and 48 were randomized to oral anticoagulation, to no oral anticoagulation, and later on 1 individual withdrew from the study because he wanted to go back on his oral anticoagulant. So if we look at our baseline demographics for this trial, as I said, in total, we included 151, and the breakdown by group is there. You can see it's a standard AFib population, mostly an elderly population, where pretty much 70% were over the age of 65. About a quarter of the study cohort was female, and the vast majority of patients were on hemodialysis, despite us really trying to include peritoneal dialysis patients. And again, it might be a little bit easier to include hemodialysis patients because they're really a captive audience that we see 3 times a week, whereas PD is mostly outpatient based, and we don't have that ongoing interaction with them. It's fairly like a standard dialysis vintage. The mean time on dialysis was 2.5 years. If we look at the pre-existing conditions, about 13% of individuals had a previous history of stroke. A large majority were hypertensive and diabetic. Interestingly, 1 individual who had calciphylaxis got into the study. And about almost 10% of individuals with a prior bleeding event were included in the study. The mean CHADS VASc, so everybody met the CHADS 65 criteria, but the mean CHADS VASc score was 4, which is pretty much standard in the dialysis population. There were a number of concomitant medications that individuals who were enrolled in the trial were taking, and the majority, about a third of patients were taking concomitant aspirin at time of enrollment, and about 40% of the study population was on warfarin, and 2% was taking apixaban. In terms of the 51 patients who were randomized to the apixaban, 26 were in the 2.5 milligram group, were randomized to 2.5 milligrams, and 25 received, 5 milligrams of apixaban. So if we looked at what happened at 26 weeks with these patients and see if we met our feasibility outcome, again, for the total population, we had 151 patients, 149 completed the trial, and as I mentioned, 2 withdrew. There were 48 individuals on apixaban, 40 with 48 apixaban completing the trial, 40 of warfarin completing the trial, and 61 receiving no oral anticoagulation that completed the trial. And in terms of the number of individuals who remained in their assigned treatment group at the end of the trial, 83% of individuals did. So that met our feasibility outcome number 2, where more than 80% of individuals remained in their treatment group at the completion of the study. What's interesting here is when we look at the patients who started the trial on a treatment group to see where they ended up. So as we can see in the apixaban group, the majority of them at the end of this study remained on apixaban. Only 4 of them switched to a no oral anticoagulation. In contrast to that, if we look at the warfarin group, a large majority of them, 32%, had actually switched off warfarin to no oral anticoagulation, and this wasn't really for bleeding events. As we can see here, the 16 patients in whom, I'll just go back. The 16 patients in whom their warfarin was discontinued, there were 4 cases were due to bleeding events, and there were 2 major bleeds and 2 clinically relevant non-major bleeds. 5 individuals on warfarin didn't want to be on oral anticoagulation anymore and switched to the no OAC group. And 7 had their warfarin stopped in the context of medical procedure, and for some reason it wasn't restarted. We don't really have the granularity to determine what happened there, but as you can see here, the take-home point is that whereas the apixaban and no oral anticoagulation individuals randomized to those groups remain in their groups at the end of the trial, there's a large amount of movement in the warfarin group, and that really has implications and ramifications for a future trial, which I'll discuss which I'll discuss shortly. If we look at clinical events, we could look at them in their totality, and we could look at them by group as well. Interestingly, there was only 1 stroke event, which happened in the no oral anticoagulation group, and it was adjudicated as a hemorrhagic infarct, meaning it was a hemorrhagic transformation of a primary ischemic stroke or a primary intracerebral hemorrhage of a hypertensive type. There was 1 TIA event, which was a probable sensory TIA in the apixaban group. In terms of bleeding events, in total, 17% of individuals had a bleeding event, and the vast majority of individuals who bled were on warfarin. Major bleeding events were accounted for approximately 5% of the total bleeding event, with most of the bleeding events being clinically relevant non-major bleeding events. And this is what we had seen also in renal AF and in Exadia. The most common site of bleeding was in the GI tract, and a third of patients who had bled were on aspirin concomitantly at the time of their bleeding. You could see here, that the time in the therapeutic range was actually quite excellent for a dialysis population. It was 58.1%, and that's really the highest amongst all of the randomized control trials that were done. And despite that, warfarin patients bled. If we looked at individuals who received apixaban and compared the 2.5 versus a 5 milligram group, each of them had 1 major bleed, 2 clinically relevant non-major bleeds, and 1 minor bleeds. What's also striking here is the mortality rate, which was about 10% over 6 months, and most of the deaths particularly occurring in the warfarin group. So a very high mortality rate. So just to summarize safety, in this trial, we demonstrated our feasibility outcomes were met, both in terms of recruitment within the time period, if you account for COVID, and in terms of protocol adherence. Bleeding and mortality events were much more common than thrombotic events. And this is sort of a comparison table here of our study to the other 3 randomized control trials that compared apixaban or rivaroxaban to vitamin K antagonists. What you could see in safety, we had a much higher time in the therapeutic range, but common to pretty much all the studies, there were very low numbers of strokes, both ischemic and hemorrhagic. Major bleeding occurred, but not as much as clinically relevant non-major bleeds. And the mortality rates were quite high in all of these studies, which indicates that we have a very fragile population here. So what do we learn about this study, and how can help us devise a future study? Well, firstly, I think what we learned was that there were a number of eligible patients that could have been included in the study, but were excluded, and mostly due to the unwillingness of individuals or their clinicians to have them participate. It could be because of clinical inertia. You know, somebody who's doing well on an oral anticoagulant doesn't want to rock the boat, which is totally fair. And somebody who's not on an oral anticoagulant, you know, doesn't want to start something that could give them a fatal bleed. You know, clinicians may also have not been very certain about enrolling patients into the study because, you know, and maybe they were relying on other individuals or other people's opinions as to enroll. But I think what the study showed is that there's clear equipoise for this question, and we really have to work hard in the next study to address this exclusion of eligible patients. The second issue is there are tons of discontinuations for the warfarin group, and not only because of these discontinuations, but also because of the issues that I had indicated to you previously. I think that warfarin is likely not going to be an appropriate choice for a future trial, and it'll really look at apixaban as the oral anticoagulation versus no oral anticoagulation. And we really have low thromboembolism rates. And so in a future trial, if you look at, you know, the traditional outcomes in AFib studies being a decrease in stroke and systemic embolism, you're going to have to recruit like a really massive sample size, or go on and do the trial for you know, tens of years, which is impractical. There is a study in Sweden, the SAC study, which is looking at apixaban versus no oral anticoagulation, and their primary outcome is thromboembolism. It's an event-based study, which I think they have to demonstrate about 250 stroke events in order to meet their power calculations, and it's really not. I don't think that's really feasible, and it's quite impractical to do. So, just to briefly summarize before I take your questions, I hope that I've demonstrated to you that atrial fibrillation is highly prevalent in patients receiving dialysis. That the optimal strategy for managing such patients with oral anticoagulation is still unclear, and doing a definitive randomized control trial is certainly feasible. And Ron Wald and I are I've told Swap and Ted that Ron Wald and I are looking at applying for a CIHR grant to do this study in the fall, and we're certainly going to be in touch with some individuals in your group to help us with this study. So in summary, I just want to acknowledge really a number of people who made this study possible. You know, we had a great, aside from my partner Ron Wald, we had a really great steering committee, and Manish was an integral part of it. I want to acknowledge our clinical sites in Canada and all the investigators and the research coordinators that were involved, including at your institution with Ted and Jennifer and Justine. And finally, and most importantly, our patient partners and the patients who decided to participate in this study. We're really thankful for their time and their trust in us, and for wanting really to be quite altruistic and helping to answer an important question. And so now I will take some questions.
Steve, thanks for a great talk. So Swapnil unfortunately had to step out. He's on drop-off detail today, so he asked me to step in to moderate the discussion. So I think we'll start with our sort of local anticoagulation and dialysis expert, Dr. Zimmerman, question.
Thanks, Ziv. Like was said, I've been asking this question for about 20 years, and congratulations for trying to answer the question. But it's very interesting when we've looked at some of our other randomized control trials, the number of eligible participants who refuse is actually really quite high. And I don't know, maybe you're aware of literature where we've actually done focus groups to try and understand what these barriers are, because I think until we can sort that out, we may be challenged to economically do this kind of trial.
Yeah, and I certainly echo that point. It's I'm not aware of any sort of like focus groups that have been done, and it certainly would be very worthwhile to do that. We really, when we undertook this trial, there was a lot of, sometimes patients had a lot of apprehension, rightly so. You're giving them something that could potentially cause a lot of morbidity and mortality, or you're taking away something from them that could potentially prevent that. And what we did is we tried to coordinate with their other care partners, their cardiologists, their family physicians, sort of to provide a consistent message and consistent messaging about the importance of the trial and what the trial entails. And a lot of times patients needed buy-in from their cardiologists or their family doctors, and I think that helped quite a bit. We were actually quite successful when we were doing that. But there's really, you really need a lot of outreach and a lot of education to help make the trial happen. But it was, I agree with you. It's hard. It was hard to recruit, and certainly that's weighing on us as well in terms of the future trial.
Next question is from Dr. Podimo at McGill.
Hi. Hi, Ziv. I don't think we've met, but what an outstanding talk. It was really totally enjoyable, and congratulations on succeeding where so many others have not managed to. I was intrigued by the TTR of 58 in your study, and the fact that most of the bleeding and dying was in the warfarin group anyway, and wondered what you made of that. Yeah, and think about McGill too. Bring on. Yeah, we're here.
Yeah. Okay. Great. Well, it's great. You were McGill was a great site, and I know Dan Bloom and Tom Avercanis were heavily involved in the study, and we thank you for participating. I think that patients that tend to participate in randomized control trials are certainly selected for in a way. They're maybe some of the more motivated patients, the more fastidious patients in terms of looking after their health. So it could be, that may have contributed to why the TTR was so high in this study compared to other ones. We also gave a handout as to how to adjust the warfarin dosing, and perhaps that standardized dosing regimen that we gave was consistently applied to all study sites, which may have contributed to such. And maybe just in terms of patients being, this is a sort of like a Canadian study where a lot of the dialysis units have a lot of clinicians and nurse practitioners interacting with their patients. Maybe there was a lot of monitoring and managing of warfarin there to help get the time in the therapeutic range so high. So could be a number of factors there.
Cool.
Thanks.
Thanks.
Oh, okay. Todd from Service A office.
Hi, hopefully you can hear me okay.
Yeah, perfect.
Anyway, great, wonderful talk. A little bit more practical question for you. First of all, your evidence, I think, was great, and I share a lot of concerns about the warfarin, and it certainly looks like that looks like the least appetizing of our options. We're struggling right now with our transplant or transplant eligible populations. So, this tends to be a bit of a younger dialysis population that probably has a longer life expectancy, that's not expected to have quite as much of that competing comorbidity. And our transplant surgeons do not feel that they can operate when they're on DOAC, and would like all of our transplant eligible patients on warfarin if eligible. Have you practically thought about this issue within your own program, or talked to others about this issue, and then how are you managing it?
Yeah, so that issue came up during the study, and we did have like a few patients. We always have a few patients that come in from community sites to get transplants here at St. Michael's Hospital, and invariably some of them are on apixaban. We worked with our hematology groups and our transplant surgeons here to come up with a protocol as to how to manage these patients, and we have a nice algorithm that I'd be happy to share with you. But the fact of the matter is, usually when somebody is called in for a transplant, especially if they're on apixaban, it's rare that they're called in and then they get the transplant within 6 hours. They're usually called in the day before, the night before, and you have that 24-hour window in order to ensure that the apixaban has been eliminated sufficiently enough to prevent an increased risk of bleeding. So practically in most cases, we haven't had to cancel any surgeries because somebody has been on apixaban. The other practical aspect would be, that we thought about was, well, maybe the people that are in the top 10% of the transplant list that maybe are going to be called within the next few months, maybe change those to warfarin. But again, in terms of doing a larger trial, I don't think warfarin is going to be an appropriate agent to use. So I think there are ways to do it practically. It just needs individuals to sit down together and sort of come up with what each site is really comfortable with. And I'm happy to share with you offline that algorithm that we came up with our hematologists and our transplant surgeons here at St. Mike's.
Yeah,
I don't see any other. Oh, sorry, Todd.
No, thank you very much. Maybe I'll contact you after. That would be great.
Sure.
I don't see any other questions in the chat. I just asked. Oh, we have a question from the conference room.
Navigating, so it's hard. Hi, Ziv Harel. Great talk. Thanks so much. Common question, which Swapnil's going to hate me for, but we were just saying that there is now a reversal agent for apixaban that's approved in Canada. And in fact, I was speaking thrombosis, and it's very expensive, but they will bring it to our hospital. I suspect many hospitals. So for the rare cases where an apixaban dialysis patient really needs that transplant within 6 hours, there will be an option.
Oh, one more question.
Oh, Brendan, sorry.
A question regarding aspirin. So I know aspirin is a little bit out of style for a number of reasons, but the reality is that there is really good old data in the general population that it reduces the risk of thromboembolism with atrial fibrillation. And the reality is, from some of the data that you showed, a lot of nephrologists are actually using it in patients with atrial fibrillation. It seemed to be the next most popular approach to no anticoagulation at all. I'm wondering, was there any thought to having an aspirin arm in your pilot study, and if not, why not?
So we didn't have an aspirin arm. We thought that for the most part, a large majority of our patients have underlying cardiovascular disease, so they'll probably be on aspirin anyways. I know, like in the general population, that even if your CHADS VASC score is above 1 for men or above 2 for females, that individuals are started on anticoagulation. And aspirin is sort of fallen to the wayside in terms of an appropriate therapy for anticoagulating patients. It doesn't really, it's not an antithrombotic agent per se, and doesn't really get to the underlying pathophysiology of why clots form in individuals with anticoagulation. So I think that was probably the reason why we didn't want to include that as an arm in itself. And we also know that the vast majority of individuals who are receiving dialysis, hemodialysis, are also getting some degree of anticoagulation through their circuit, right? And maybe that's having some effect as well. But we didn't specifically want to do an aspirin arm, both for practical reasons and for that. Deb, I know you had a question. I just can't read what you wrote.
I think so. I think Deb, do you want to?
So I was just playing devil's advocate because you talked about the tremendously, surprisingly low thromboembolism risk associated with AFib in the studies. And so if you can't do the RCT with this as the outcome, do we need to do the trial? Because just doing an RCT saying, oh, the bleeding risk is acceptable, that's great. But if it doesn't actually prevent you from having a stroke, it's irrelevant. Yeah, no, absolutely. And I think the type of stroke is also important, like heaven forbid, like a catastrophic stroke where somebody's like hemiplegic is completely different than like a minor stroke where somebody has some aphasia thereafter. And there's also various gradations of bleeding, right? Like a major bleed isn't is much worse than like a minor bleed. So I think you have to sort of look at those types of permutations when deciding. So I think in terms of just looking at the worst case scenario, considering the risks are small, considering the numbers of those really bad strokes are low. I'm not sure if I'm just going to stop talking because you did make a good point. And I don't have an answer. It is a good thought. It is. And in I'm terms just of imagining females, the CIHR panel, right? Looking at it. Yeah, going, no, it is. And it's something that we're going to. And in terms of females, we actively listed that when we wrote our paper, which is in review right now. We did address that in our limitations. Females make up almost 44% of the dialysis population who have atrial fibrillation, and we only recruited 25. So we really need to make a much more concerted effort to enroll them. I think we were just happy that that we enrolled patients in the study. But going forward and doing a definitive study, we really need to focus on including. Yeah, Ziv, that question was really about, there's been data before about females being more risk averse Whether that still bears out today, I don't know. But if we're under recruiting, is it because we're not approaching, or is it because they're saying no? And if they're saying no, how do we actually address that to make sure that they are represented appropriately in trials? It wasn't meant to be a criticism at all. It was more, why can't we recruit them?
Yeah, and it's a very important point, and we highlighted that when we wrote our paper as well.
Yeah. Okay.
So we're at 5 after 9. So thank you very much. Again, great talk. If you're actually able to stay for just one last question. So
Sure.
For the TTR, you know, it's relatively good. You know, at our center, we have thrombosis managing all the anticoagulation with warfarin for our patients on dialysis. So what was the range? Like, was there a lot of variation across centers in terms of the TTR? Is that relevant at all of your?
Yeah, I don't have that data offhand. We didn't specifically look at that. It's a good question, and I think that it's something that we'll want to look at. I can't remember what the interquartile range for the TTR was. I can give it to you offline. I could.
Anyway, offline. I'd just be curious locally how we do too.
Sure.
Okay. Anyway, thanks. Thank you again. Great talk, and we're looking forward to being part of the next steps.
Yeah, absolutely. Thanks for inviting me.
Okay.
Have a great sunny day. I hope it's sunny in Ottawa too.
It's great here too. Enjoy.
All right. Bye.
See
Take
ya.
care, everyone.
Bye.